It is the pleasure of the Northwest Business Club to introduce the Executive Director of the Whatcom Alliance for Health Advancement. He is the past executive of the Skagit Valley Medical Center, and he has also been self-employed in the healthcare industry, as well as been a consultant in the healthcare industry for the past 35 years. So he's got a lot of experience. He is the father of 2 children. He's been a resident here for over 20 years. And so let's put our hands together and welcome Mr. Waha himself, Mr. Larry Thompson.
Well, thank you for inviting me, I think. We'll see how this goes. Usually I get invitations to different sorts of audiences, so I actually look forward to this because I do come from a background where in my role I'm supposed to be as nonpartisan as I can and tell it like I see it. So that's what I'm going to try to do today, and I'm sure that we have enough people in the audience here who will ask me questions and keep me on straight and narrow on that. So with that, let's roll. So our program today is about the enormous changes going down right now in medical care, and with an emphasis, I was asked to talk about what's going on with Obamacare and what I know about what's different now and how's it going. So our session outline, I'm hoping this thing is, push the top button.
That doesn't work, we'll advance it for you. Maybe not.
Okay. Sorry about that.
All right.
I have to move away from.
There you go.
This didn't work very well either. So I'm going to cover several things in the course of the next half hour. What does WAHA do? What's the case for change? Why think about healthcare reform? What's going on with Obamacare? And what Obamacare does not do, at least part of that. So I put the kind of, sort of. And then I'm going to talk about some of the local initiatives to reform healthcare in somewhat related ways. So, next slide, please. So, the mission of WAHA, where I work, is to connect people to care and facilitate the transformation of the healthcare system to achieve better quality, moderate the growth in costs, and create greater satisfaction in the healthcare process for both providers and consumers. WAHA as an organization has been around for about 10 or 11 years now, grew out of a community process. We're a private nonprofit. We're funded through a very wide variety of grants, contracts, and charitable contributions and the like. Basically, our mission is in 2 parts. Half of what we do is to deal with the problem of the uninsured people in Whatcom County. The other half of what we do is what we call advancement, and that's the harder part to talk about. But let's talk about the access first. So we've been working on access issues for at least 8 or 9 years, well predating the Affordable Care Act or Obamacare. And to do that, we've had a couple of roles. One role has been to help people sign up for the existing insurances that exist that were out there prior to Obamacare. For example, the state Medicaid program and the basic health plan while that was active in the state. The other part of what we do is that a lot of people were unable for various reasons to get insurance, so we tried to plug them in directly to donated medical care of various sorts. And that donated medical care is either medical or dental or mental health care. And one thing that you may not realize is that almost 85% of all the physicians in Whatcom County have been donating their services for free to uninsured people for quite some time. On the dental side, it's a newer phenomenon, about 35% donate care. So we've had donated care programs and programs linking up with insurance vehicles, and so that was, for WAHA, a predecessor activity to the Affordable Care Act. The other half of what we do is what we call the advancement mission. And the WAHA board, which is about 20 or so community members, is of the view, and you'll see that right in the details of our mission statement, that the healthcare system as we know it today is not functioning particularly well, could perform considerably better. And so we're always looking for ways to get the delivery system to perform better, and to, in the course of doing that, to improve quality of care and reduce cost. And we'll go into several examples of that over the next few minutes. So next, please. So first topic area I'm going to cover here is what's the case for doing anything about changing medical care. Next. And next. So, next please. And then one more. So this slide here is talking about the cost of medical care from an international perspective. And this line right here, this top line, it doesn't seem to be showing up for me, but the top line that's red on the left-hand side is the per capita cost of medical care in the United States. And then the series of lines below it immediately are the cost of care in 7 or 8 other random developed countries around the world. And what you can see there is that there was a time back in the 80s and 70s when, from a per capita standpoint, healthcare in the United States was not all that much more costly than it was in the rest of the world. But those trend lines have diverged quite radically over the last few years. And if you take that back even further into the 60s, all of this cost growth really begins to be evident at the time of the passage of Medicare and Medicaid around the 1960s. On the right-hand side of this slide is the percentage of the gross national product that is consumed by healthcare as an industry in the United States versus other countries. And again, you see this pattern of the United States outstripping others. This data is actually several years old. It's currently about 18 cents out of every dollar is consumed on healthcare. Next, please. So you might say that we're spending an awful lot on medical care, but we're also getting better results than the rest of the world, right?
Yeah.
Well, the data would suggest that's not the case. And you have to think about this in an aggregate basis, and on an aggregate basis, not an individual basis. Certainly on an individual basis, healthcare in the United States is fine, it's excellent. We have highly skilled people, wonderful technology, but the care is uneven from person to person. So when you take a look at aggregate statistics, you see that our lifespan on average is less than many other countries. Next, please. The infant mortality rate is less than many other countries. Next, please.
Where are we at?
Yeah, where
Well, we're right here where the red line is. We're at 6.5 per thousand, which there's about 180 countries in the world that get tracked by the United Nations and other organizations. So
the same standard for mortality from country to country?
the same standard, yes.
Yes, so it's
Yes.
the same definition.
Yes.
Is it fair to ask a question? We're a country of immigrants, and we've had this huge influx of people from south of the border who don't necessarily have great health when they arrive here.
Yeah.
So don't they affect this to a huge degree compared to other countries on the planet?
Well, absolutely. And it's not just the immigrants. It's, I think we probably better hold the questions.
Okay.
We have a half hour for later, but I will address this one. Yes, the problem is you can go from one community to another and health status varies very markedly. So our problem is not that we have some people who are doing quite well on all these markers, better than the rest of the world, but we have a lot of people who aren't. When you average it all out, it doesn't look so good. Okay? So next slide, please. This is one of my favorite slides. Hopefully this will translate for you about the cost and quality conundrum in the United States. On the left hand, this is data from the Medicare program, but the same phenomenon occurs in Medicaid or in private insurance and others. On the left-hand side of the page is the quality ranking by state, and across the bottom, going across there, is the amount Medicare spends per beneficiary per state. And the striking thing about this is the amount spent is inversely proportional to the quality of care in the state. So you have Louisiana that ranks dead last on quality, also happens to be the most expensive state. So what I take out of that is that the more you spend on health care, it does not necessarily equate to better health for people. And what we have is a kind of a spending machine out there in medical care. Next, please. So this slide is about what I think is an emerging consensus among people in the healthcare field, meaning doctors, hospitals. And when I say consensus, there's certainly not unanimity, but I've recently seen some survey data from physicians across the state and other people that are professionals in healthcare. And there's a widespread feeling, there's actually two widespread feelings. One is that what we're currently doing in medical care isn't working and probably isn't sustainable very much longer unless we make some fairly significant changes. The second set of views that emerge from survey data in this state and in many states is that the way we're paying for medical care right now is a big part of the problem. We pay what are called fees for services, so we reward doing more things for people rather than getting good outcomes for people. And there are ways to pay providers that, for example, would reward them for better managing diabetes or depression or outcomes, conditions of healthcare. Next, please. So we live in a bit of a bubble. Keep going on that. And this slide is intended to say that what we have is this kind of building crisis, a bubble of costs that are unsustainable in healthcare, and bankruptcies at an individual level, the leading cause of bankruptcy being medical care, and just lots of side effects that threatens to burst at some time in the next 10 years. Next, please. Yeah. So, one of your favorite signatures, I suspect. Right? So, the legislative solution at the national level for all of this that I've been describing was the Affordable Care Act, which is, of course, a massive document that has so many provisions in it we couldn't begin to cover it in a half hour's time. So I'm not going to be able to do justice to all of the different themes and alleyways that are in that act. But first of all, is health reform a new concept? Next, please. These slides are just showing some of the prior attempts at health reform in the United States, and actually it goes all the way back to about 1928. Next, please. Whoop, I think I skipped a slide maybe. There we go. So back in 1993, probably a lot of you will remember this, we had Hillary, who was promoting a brand of managed competition. And then we saw was it Harry and somebody, there were ads that showed the demise of private health insurance. You probably remember that. And those ads were very effective, and among other things, that initiative went down the tubes fairly rapidly after its introduction. The key from one angle on the politics of it is the insurance industry was adamantly opposed to the Hillary Care approach back in the 90s and put the bulk of the money into the anti-campaign at that point in time. If you go forward to 2010, what you see is that most of the healthcare industry was lined up behind the Obamacare initiative. Of course, you didn't call it that at the time prior to its introduction. So most of the health insurance industry, not all, flipped from anti to pro because they saw some business opportunity in this. Likewise, the American Medical Association was on record as supporting Hospital Association and many others. And so you got almost, I think, a unanimity of Democrats that voted in favor of this. There might have been maybe one or two that did not. So it became law back in 2010, and of course we all know about the constitutional challenges. Next, please. So very long, and this bill will provide the greatest increases to healthcare access since 1965 with the passage of Medicare and Medicaid. And it has two goals, one of which is this expanded coverage for the 32 million people who are currently uninsured. I think that number is actually closer to 40 million these days. And to slow down the rising cost of healthcare. Next, please. So some of the highlights of what's in the act are on this slide here. First of all, there were a number of structural changes to the health insurance industry, and that's the first set of bullets up there. Most of these provisions took place and were enacted back in 2011 and some in 2012. So these are things you probably have heard about, like no lifetime limits on spending under health insurance policies, being 26 and being able to be covered, and you can read the text there. The second category of things that are buried in the Affordable Care Act is expanding coverage. And that comes in a couple of dimensions. One is that Medicaid in, I think it's about 24 states is very greatly expanded. And in the remainder of the states, the state governments have elected not to expand coverage. And that was made optional by a Supreme Court ruling back about a year ago. There is also the individual mandate, which I will talk about in a minute. And there's a responsibility for large employers, which was delayed a year, to offer health insurance to their employees. Next, please. So this slide tries to give us a sense of who might be eligible for expanded coverage and puts it into family dollar terms. So that top line, apologize, my pointer doesn't seem to be working all that well, where it says 100% is the current Medicaid eligibility limits, family income of 3 under $20,000 roughly. So Medicaid is expanded to cover people up to $26,951 as a family of 3, so that's a pretty hefty increase. But the real big increase is in the subsidized health insurance part, the so-called the exchanges that you hear about. Oh, thank you. So you can see those are fairly hefty numbers for income. And I happen to know off the top of my head what it is for a family of 4. It's about 92,000 income are eligible for some sort of subsidy. And it's a sliding scale subsidy that's applied to coverage. Next, please. So the next slide is going to show a little bit about who's currently uninsured. If you could switch that. Yeah, thank you. So there's roughly 700,000 to 800,000 people in the state of Washington that are uninsured right now. And the Affordable Care Act, as structured, would add roughly that many to Medicaid, and then this many to the subsidized tax credit approach. This many could buy health insurance on the exchange, and then about 13% of the current uninsured would not be eligible for any kind of coverage under the Affordable Care Act. Those individuals are, the bulk of them are undocumented aliens. There are also some people who are fit in various other quirky categories, but the big, most politicized group there would be the undocumented. Next. So we have this new state agency, basically, called the Washington State Health Benefits Exchange. And it went live on the first, it went kind of sort of live on the 1st of October. And the way that people interact with the exchange and the new coverage is through one of 5 vehicles outlined on this slide. So you can access this coverage through your agent or broker, as people have for many, many years. And there's several thousand brokers in the state that are quite enthusiastically working this to see this opportunity. There is a call center over in Spokane that was set up specifically for this purpose. It's getting about 12,000 calls per day and was built for a call volume of around 2,000 calls per day. So it's a little difficult to get access to that call center. There are, the original idea was that most people would self-direct themselves onto this website, Washington Health Plan Finder, and come up with insurance that way. And that the estimates going in were that probably 80% plus of all people would simply go on the website and sign up. And that certainly has not been the case at a national level. You've all heard about the, I think it was gov.com or something like that. It's the national website, or even on the state's website here in Washington. So that leaves getting in through the call center or the in-person assister programs. Now these are human beings. At WAHA, where I work, we've been doing that for 10 years prior to Obamacare. We're continuing to do that. But we have a continuing line of people all day, every day, who are looking to sign up for some kind of coverage. Next, please. Now you've heard, I'm sure, about the individual mandate and the tax penalty that occurs. Everyone under the Affordable Care Act is required to have insurance or pay a penalty. And this was one of the most heavily litigated issues in the Supreme Court decision. But I thought it might be interesting if you could see in dollars and cents what that penalty is. So that's what this slide is doing. Penalty this year is $95, or it would actually be for next year. And then it increases in 2016 up to almost $700. Next, please. So on this insurance exchange, there's 2 different kinds of products you can buy. You can buy what's called an individual insurance product. That's you and your family just have coverage directly. And on the right-hand side is coverage through your business. And from an insurance perspective, those are entirely different markets. They function really differently. In this state, We have about 7 different health insurance companies offering about 40 plans on the individual market. And that is the situation there. Over on the business side of our state's market, we have only one plan, happened to be Kaiser Permanente, put in a bid, and that was for 2 counties in southwest Washington, for Clark and Waukegan counties, I think it was too. So the health insurance companies basically were not interested at this time, took a wait and see approach on the small group market. Small group is considered to be any firm with less than 50 employees. Next, please. Another angle on the Affordable Care Act is that the Act sets out essential benefits. These are things that must be covered in insurance policies as of next year. So you probably heard about the cancellation notices that some people have been getting. That relates to this. So cancellation notices have to do with insurance companies offering products that don't meet one or more of these essential benefits. So someone somewhere determined that the policies were not adequate and therefore needed to be canceled and replaced with new policies either privately off the exchange or on the exchange. Next, please. This slide here is just a screenshot of the benefits exchange. And the benefits exchange in our state has been functioning considerably better than the national benefits exchange, and but not at all at the standards that I think any of us here or in any political persuasion would want. The success rate on the exchange has been around, depending upon the site, somewhere between 15% and 40%. So in other words, roughly that proportion of people trying to get insurance have been successfully able to do that. And the reason are technical glitches in the website and the sheer complexity of the thing. It is far more complex, frankly, than I think was anticipated by the framers of that website. But that being said, if you're in the state of Oregon, they're not even up and running yet. You can look at things, but you can't yet purchase on that exchange in Oregon. So next, please. To deal with the confusion that's out there, oh, wait a minute, let's go back one. Whatcom County, this is just a slide of how many people are uninsured in Whatcom County, 19,400. And so far, we're not getting good data out of the exchange about how many people have signed up, but it looks like in Whatcom County about 1,200 to 1,500 people have signed up with, and that's in the first month of offering this, with approximately 80% of those being people who've signed up for Medicaid. So the Medicaid option has proven to be more popular, as you could expect, than the subsidized health insurance product. One thing that is often said about the subsidized health insurance product is that you don't have to pay for that until November or December, so there is a belief out there in some parts of the world that there will be a larger proportion of people coming in on the subsidized side in late in the year. Hang on just a minute, I'm almost through. Hold those questions. So I think I've run through pretty much all my time. I have a number of slides that talk about some of the things that are going on in Whatcom County that are peripherally related to the Affordable Care Act, but we're not going to have time to probably get into those today. But hopefully this gives you some fodder for your questions. All right. Oh my goodness, there are questions.
When you get called upon, stand up and give your question, and members will let you call it, whatever you
Okay, let's start over here.
Ladies first. Thank you. I've been running figures for a couple of years for a pilot project.
Name?
Who are you?
My name's Ellen Baker. I've been running numbers for a couple of years for a pilot project in Indiana. It was an advanced Affordable Care Act pilot. And I've learned through running the numbers that costs have to be reduced. Organizations have to show reduction in costs to keep their Medicare whole. First they were withholding 2% and 3%. By 2016, Medicare reimbursements are going to be withheld as much as 4%. And I'm concerned that that's sort of a disincentive to increase access and increase the level of service, because of course it costs money to provide more service. And I see that as a concern just through my accounting experience. And I'm wondering how that, is there a plan for Whatcom County to actually improve medical access? How are you going to do that? I saw pharmacy costs cut. I saw visiting nurses canceled, and all sorts of mechanisms to make it look like medical care is costing less. How are you going to show a reduction in cost?
Good question. So there's at least 3 questions or 3 points in there.
How will you show a reduction in cost while you're increasing?
You talk about the Medicare issue first and the tax cut issue that gets talked about a lot. The Affordable Care Act does include some cuts in Medicare, and they are the following. There were 1 or 2% cuts to certain provider organizations, principally hospitals, certain others as well, and that was negotiated with the hospital industry as a trade-off for expanding the number of people that were covered through insurance. So that was kind of a voluntary tax cut. The second provision, or expenditure cut, the second provision is for a program called the Medicare Advantage program. Medicare Advantage is Medicare through private insurers. And for a number of years, going back to about 1998 or so, the Medicare Advantage program has been subsidized by the government to try to encourage more people to buy private health insurance as opposed to traditional Medicare service. And that subsidy is being reduced down to about 3 or 4%. Now, the fundamental question, I think, is what is going on here to reduce cost? And I think the way I'm going to answer that is there are a series of very incremental, very small starting initiatives to try to make the utilization of services more efficient. And I was going to go through some more detailed example of that in my presentation, but ran out of time. So let me give you an example. It turns out that if you look at the total cost of care in Whatcom County, there's a minority of about 5% of the population that uses almost 50% of the cost of care. And a lot of that care is care that, from a medical standpoint, is not needed. So I'll give you an example. We had an individual out in the Everson area who called 911 for an ambulance transport in excess of 100 times in the course of a year. And each ambulance transport is in the range of about $700 to $800 cost. Somebody's paying that. And then, to top that off, once you get to the emergency room, which is the only place that the ambulance can take you, you're looking at another $1,000 bill. So each transport, you know, you can do the math. And so what was going on with this individual? He had an acute anxiety disorder, and he was off his medication, and no one was communicating with him to get him to be on his medication. So by getting him into a case management program and linking him up with a primary care doctor, they were able to reduce that utilization down to less than 5 trips in the course of a year. So it's little things like that that really need to be done to squeeze the waste out of the system. And Lord knows we have huge waste in the medical care system.
Yeah, Bill.
Bill Geiger. I need a point of clarification before I ask my substantive question. That is, does WAHA receive funds from the federal government to explain, educate, otherwise place the Obamacare program to the general public?
No, we don't receive funds to place or explain the Obamacare program to the general public. We do receive funds to help individuals to enroll in either Medicaid or in subsidized health insurance coverage. But when I'm out here talking with you, this is paid for by the charitable contributions that go to WAHA.
But otherwise, you do perform a marketing function or otherwise transaction function for individuals entering the system.
We are strictly prohibited from performing a marketing function.
Okay.
So if you find us performing a marketing function, we're doing wrong.
Okay.
But we do a transaction function, that is correct.
My core question is this. There are at least 5, maybe 6 cases that have gone through the U.S. Court of Appeals that are now pending before the Supreme Court that focus on the issue of either business mandate or individual mandate as to participation in Obamacare. The most recent case 2 days ago found in favor of the individual who is opposed to what Obamacare is doing. My question on the business model, since you're an executive in the health industry field, is should that mandate be taken away? That is, the Supreme Court says the mandate is unconstitutional. Do you see the business model of Obamacare as it's currently structured collapsing?
If the insurance mandate is taken away, this is a personal opinion. I can't purport to know the absolute fact of that. But if it is taken away, it will be the insurance industry that will be crying foul and will be far less likely to offer health insurance products on the exchange. And they will do that because they will come to the belief that they will be adversely selected against if only the sick people end up enrolling. And so that's kind of where they're coming from. And the insurance industry, I would predict, would start heading for the hills really quickly if the individual mandate collapses. Yes, sir.
Marty Moskowitz and Kim Moskowitz. I want to share a little anecdotal with us, just what happened, and maybe get your take on it. We are one of the canceled policies with Regent Blue Shield. Apparently our policy is substandard because we don't have maternity coverage and substance abuse coverage.
Louder, please.
Okay, I'm sorry. We're one of the canceled policies. We carefully shop our policy every year. It is the replacement policies that were offered to us by Regents were about $400 more a month and about double the deductible. We were also encouraged in that letter to go on the state exchange to see what we could get there. So went on the state exchange, not initially because I couldn't get on. Eventually, about a month later, was able to complete an application, but got very confused because we are self-employed, have been for over 30 years, and have widely varying income to the tune of sometimes negative adjusted gross income. There is no means testing on the website that asks anything about do you own your home or do you have bank balances or anything. It's strictly what is your net income. We don't have a net income. Suddenly I find myself approved for Medicaid. I don't want Medicaid. I don't know how to undo this process. So I'm stuck. I don't know where to go. I was like, you're laughing. Okay. I knew it. So where do you go? I tried calling the phone number, the call center, and you basically punch through about 4 menus, and then they get a recording that says, we can't take your call, and there's a dial tone. So there's no messages, there's no place to go. How do I undo this?
Marty's on welfare.
I think vote for Obama now.
What you need to do is to go to one of the in-person assister locations and around Whatcom County. So one of those would be WAHA. So give a call, set up an appointment. come in and discuss your situation, and I doubt that the intent would be to force you to take Medicaid, so we'll see what we can do. But there's no question about it that there are a number of people whose policies were canceled, as yours.
My daughter's was canceled.
Yeah, or in your family. We have one Waha board member, for example, whose cancel policy created a similar situation, what you're describing. So that's what we're there for, is to help you puzzle through this. Most of us aren't spending all of our time thinking about medical care, so you know the nuances, the ins and outs. You got to find someone that you can talk with, that you trust, whether that's an in-person assistant or a broker. If you have a broker relationship, that would be another good option. Yes, sir.
Very good. Thank you for your comments. Very quick question. If Obamacare is such a wonderful thing, can you or anybody else in this room tell me why our elected representatives are not included?
I don't know the answer to that. Yes, sir.
Martin Cognac. I hear the news and everything about certain states opting out of Obamacare. Now, is this something factual, or how do they do it, or why did or they, or why did we not, or whatever?
Well, I think that's a bit of an oversimplification, opting out of Obamacare. It's not possible in all senses of the word to opt out of Obamacare.
It's just refused.
What you can do as a state is you can elect not to expand Medicaid, and quite a number of states did that. I think there were 24, 26, almost half the states. So that's one thing you can do. The other thing that states can, and some have done, is to say, we will not set up our own health insurance exchange. Now, our state set up a health insurance exchange. We opted to do that on the theory that we could probably do it better than the federales did. And yes, we have done it better than the federales, but you know, it's comparing it's something that isn't working particularly well to something that's kind of sort of working on a good day. So there's relative degrees of success in that. Yes, sir.
Randy Elmore, do your in-person assisters have background checks?
Yes, they do. Yeah.
So no felons?
Pardon me?
You have no felons working for you?
As far as we know, unless they're hiding it from us in some
Your
way.
navigators are all checked? The navigators?
Yes, yes.
You do have navigators.
Pardon me? No, they all have to, it's part of the requirement of the state exchange that they be credentialed and checked for certain things. Yes, ma'am?
Lisa Sherry. I hear you refer to it as the Affordable Care Act. My question is, in dollars and cents, how much will it cost individuals, families, et cetera, et cetera? I believe that there is still out there a perception that this is going to cost nobody anything. But I believe in actual fact, it's going to cost us much, much more than we were paying before.
Yeah, I think the data is not in on that yet. We have lots of anecdotal types of this person saved that much money and this one got $700 more expense and so forth and so on. The only thing that we have that's hard data is national health expenditure data, which is data on the total expense of medical care across the whole country, whether or not it's from the exchange or not. And what we do know there is that the cost of care for the first time in 40 years is considerably lower, statistically significantly lower in the last 3 or 4 years than previously. There's an academic debate about why that is, with some economists saying it's because of the recession, and some economists saying it's because of structural changes undergoing in the healthcare system that have some things to do with the law and some things not to do with the law. So the jury's really out on whether cost of care is coming down, but my personal opinion is that we have to do something with the cost of care, whether this is the right prescription or not. I'm not here to answer that question, but I do know that if we don't deal with the cost problem, we will not have a good medical care system in 10 years. Yes, sir, in the very back.
Richard Gale. The Affordable Care Act was sold on the basis of two things. One was it was going to save money. The other was that it was going to provide insurance to the uninsured. We've got about 5% of people that have insurance that are being told they can't have the insurance that they had. And that's what I've heard, is that being kind of dismissed by the supporters of the act, saying it's only about 5%. Do you happen to remember the percentage of American people that were uninsured that led to the passage of this act?
Yes, sir. The percentage of people nationally uninsured is around 16%, which is just a little north of 40 million. And that varies a lot from state to state. So if you go to Texas, for example, you have about 25–26% uninsured. Here in this state, we had about 15 or 16% uninsured, just a little bit less than the national average. And then we have a handful of states that have uninsured rates that are down in the 2 to 5% range. So it really depends on where you live.
Legal or illegal?
Oh, that's the total population, legal and illegal. Yes, sir.
This is John Cole. Our company was canceled, and they're giving us some different proposals. One of them is Obamacare under the silver emblem. And for example, for my wife, it'll cost $250 more per month, and there is a deductible clause. And the deductible clause says that for the first $3,000 spent, it is out of your pocket. And then Obamacare kicks in.
Okay. Are you working with a broker on that?
Yes.
Over here. Yes, sir.
Jacob Shades. Now, the Washington Policy Center has written about how the fees associated with not being covered are fees that the IRS cannot physically put a lien on. So if you play with your accountant properly, as I understand it, and make sure you don't have a refund, they could only collect that penalty if you were due a refund on your tax return. Is that correct? That if you were to situate your tax situation with your accountant to owe each year, that you would then they would not be able to collect that fee.
You know, I'm not 100% sure on that. That would be a question to ask for an accountant. I've heard the same statement made, but I personally can't verify whether that's accurate or not. Yes, ma'am.
Hi, Chris Haltman. I had a catastrophic plan, which is what I chose. Went from $556 for myself and my husband to $1,100 a month premium that I get maternity care and chemical dependency for now. And my individual deductible went from $3,500 to $5,000 or $10,000, depending if I'm in network or out of network. So I see a lot of the structuring that's going on here is going back to the HMO model, which is what a lot of what we went away from before, those in network and out of network, which they got out of it because it was so much more expensive to manage and operate an HMO as opposed to your PPOs and your catastrophic plans and your PPAs. So are we moving forward? And then my second question, this one is an easy one for you. Are you working with Regina Delahunt at the Whatcom County Health Department, and are you creating a software program to create a database on Whatcom County residents?
So a couple questions there. So let me think. The second one was, am I working, is WAHA working with Regina Delahunt to create a database? And the answer to that is yes. We are creating a database of critically ill people, the most expensive people in the county. And that is tied into trying to figure out who voluntarily might go into case management, like I described for the fellow with anxiety a while ago. So that's the idea behind that initiative, and the answer to that is yes. Could you repeat the first question?
Well, is the structure of the
Oh, HMOs.
Yeah, going back more towards the HMO as opposed to where you have the more patient-doctor relationship.
No, there does not seem to be any great increase in market share for HMOs and HMO-type vehicles. And in our state, the dominant form of health insurance is PPOs, which have a looser structure than HMOs. Our market migrated away from HMOs with a very few exceptions about 15 years ago. What you may be kind of getting at is this issue of the catastrophic coverage. And that's a very contentious point, that a lot of the catastrophic coverage that used to be available is not available because it doesn't meet the test of having all of the mandated or required benefits in it.
I guess what I'm mostly concerned about is the amount of disposable income that's being sucked out of the economy and what that's going to do come January when all that money that used to be spent going, on vacations, playing golf, going to a movie, going to dinner, whatever, is not there.
I think Dr. Goldfeld was going to get it.
Terrific. Yes. Bob Affolter. About 20 years ago during the Hillary debacle, I went to a town hall meeting because Washington State was going to be the first to put this through. Okay? I went to a town hall meeting and I asked the legislature, my question was, when we're talking about the cost of health care, we're talking about the price of a doctor visit. Is that true? And he said yes. Do you notice today that we're no longer talking about the price of a doctor visit? We're talking about the price of your insurance. We lost the debate 20 years ago. We let this switch, and now we're talking about insurance. They don't give a damn whether you can see a doctor or not. Right. If you got a $3,000 deductible, you still can't afford to go in. But as long as you've got the insurance and they're getting your money, that's great. Now my question is, you show a difference. You show a difference in the cost of care between us and other countries. Do you remember when we stopped, or when we changed the law and allowed the drug companies to advertise on television?
Well, I think that was in the 90s or so.
I think it was even before that.
I'm going to ask the last question because we're out of time. And that is, if you're successful and we get all these people signed up for Medicare or on these plans, who's going to locally take care of them? When essentially every medical office in Whatcom County is currently closed to Medicaid. Medicare's current rates pay less than 50% of the usual cost of service to the doctors. That's Medicare. Medicaid is about 35%. Who's going to take care of these people if the system is successful in implementation?
So the question is, who's going to take care of all the people that have new coverage? And the way I would answer that is that the bulk of the people who are newly getting coverage are most likely to go to the 2 community health centers. That would be Interfaith and CMAR. And the Interfaith and CMAR have been expanding to try to meet the demand for coverage for low-income people. So they have been hiring, and whether or not they're able to meet the capacity, I couldn't tell you.
We always got death panels.
Yeah.
We always got death panels.
Yeah. We should start our own death panels.
So I think there was also in there somewhere a question about whether the private doctors would be taking patients given Medicaid fee-for-service reimbursement. And the answer to that is no. They're generally not thrilled with the Medicaid fee-for-service reimbursement. So that's why payment reform in Medicaid is probably on the horizon sometime in the next year. That doesn't mean higher rates per visit. It means different forms of payment for outcomes. And most of the larger groups here are heading in that direction of shifting their business operations away from fee-for-service.
Well,
Payment for outcomes. I'm sorry.
I've got to cut it off. Will you stay and take some questions after you?